My name is Chris Powell. I'm the Director of Emergency Services for Baylor Scott & White, North Texas. I've been an ER nurse now for almost 30 years. And I also co-lead the Sepsis Committee for Baylor Scott & White in the North Texas Division. And I'm going to be kicking off this program. I am very excited to have worked with this group of people. The DFW Hospital Council, realizing the impact of sepsis on the public health in our communities in the North Texas area, put out a call earlier this year for each of our institutions to provide a representative to serve on a task force to cull out the best practices for the purposes of identifying what we want to do with sepsis and for the purposes of spreading best practices across this area. We did look at some data, we did look at the literature, we did look at what different organizations were doing, and we really feel like we have put together a program for you with some practices that you can take back to your institutions and implement and subsequently make a difference in your patients' lives, the families' lives, and the morbidity and mortality associated with sepsis. So I do want to thank all the people that are involved. I do want to thank the DFW Hospital Council for pulling us together to do this work because it is really important work that needs to be done. So the planned agenda, a brief introduction. We're going to talk about what the guidelines are. We're going to talk about how we can implement those guidelines. We're going to talk about how we can incorporate the electronic health record in helping us do this, not only document it, but prompt some of the care that needs to be done and help guide our care. We can use technology to really help us in getting this work done. We'll have some additional sepsis resources and links, and we're also going to provide some time for networking and for questions if you have those. We'll adjourn in the early afternoon. We want for the learners to be able to define and describe sepsis and the potential risks to patients' morbidity and mortality, and also take back and implement best practices in the care of sepsis patients. So let me talk to you a little bit about sepsis. So starting with the incidence and impact of sepsis, and these are 2011 numbers. We do have some more current numbers in the literature, but we really haven't seen a huge amount of change except for increases in some of these numbers, which is really not where we want to go. Sepsis was diagnosed in over 1 million patients in the United States annually. We really feel that this is being underreported. Our current ICD-9 diagnosis codes don't really allow us to call out sepsis where we know sepsis occurs. Some people in the medical record may have died with a diagnosis of pneumonia and not have been called sepsis. So there's a lot of underreporting of sepsis, and we really feel like that 1 million patients is a lower number than what we're actually seeing. In 2011, sepsis accounted for 5.2% of the total cost for all hospitalizations across the United States. That is equivalent to over $20 billion per year. This is a very expensive condition to treat. I'm sure you guys recognize that, and you've seen in your own institutions the amount of resources that we use to manage this population. So over $20 billion a year, and that has only gone up since 2011. In 2011, sepsis was the most expensive hospitalized condition across the United States. That is huge. And so again, how can we pull together our resources to take care of patients, improve morbidity and mortality rates in this population, and also reduce the total cost of care so that we're being efficient and effective in what we do. Survivors at risk for long-term physical, psychological, and cognitive disabilities. We do have a lot of these patients survive this condition, but definitely they're at high risk, and we start seeing some of the effects of that period of sepsis affect them in their long-term outcomes. And the mortality rates up to 30 to 50%. I mean, overall across the United States, we see a mortality rate of about 30%. We really, despite all of the efforts that we've made over the past 10, 15 years, we still see high mortality rates for sepsis. So again, Our purpose is to pull everybody together, talk about the best practices, and really challenge you to go back to your organizations, implement these best practices, and improve the outcomes of our patients and our communities. So I was privileged to have gone to the Marinoff Symposium in 2010. This was held in Garden City, New Jersey, and it was a global think tank. We had people there from Brazil, from Europe, from the United States. We had people from all over the globe at this Marinoff Symposium. And at that symposium, we did develop a new scientific diagnosis or scientific definition of sepsis and a public definition of sepsis, because we realized we had to start making the public more aware of the risks of sepsis, put a name to it, and put a definition to it that they could understand. But what was really striking about the Marinoff Symposium is that we met for a day and a half. And the entire time that we were at the conference and overnight while we were sleeping, this clicker was going off. And it was showing us how many people were dying every minute from sepsis. And by the end of this 1.5 day conference across the globe, over 51,000 people had died from sepsis. It was really remarkable. So, a little bit on the background of sepsis. This is really a commonly known cause of death, even going way back. People who got injured, people who were in wars would get wound infections. Some would survive, some would not. So bad wound infections, putrefactions. The word itself comes from the Greek word sepsi, which means to make rotten. Honestly, that may be the best definition out there, right? And that came about the time of Hippocrates. Dr. Semmelweis, who was an obstetrician back in the 1800s, recognized that he had a high percentage of pregnant patients that were dying from infections, and he realized that the physicians and students that were taking care of these women were coming straight out of pathology lab, and where they were working on goats and sheep, and they would go right in and do examinations on these women without washing their hands or having any kind of sanitary practices. He introduced hand washing prior to those examinations and saw a drop from 18% death in this pregnant population to 2.5. So even back then, we knew that sanitary conditions would really help us make a difference in reducing the incidence of infections and sepsis. Antiseptic practices, though, did not eliminate the incidence of sepsis. And we saw the introduction of antibiotics after World War II having a significant impact on wound infections and sepsis, and that helped. And then moving quickly forward, 1960s to 1980s, there was more and more research and literature out there that showed that it wasn't just an infection that caused the problem. There were actually some host responses that could move a patient down that journey into sepsis and septic shock, and that kind of moves us into current history. So Emmanuel Rivers and colleagues put out this Sentinel article in 2001 titled Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock. And he outlined what these patients look like, and he outlined some of the best practices that would help reduce morbidity and mortality in this population. I put the source here if you have not seen it yet, although I'm sure that many people in the room, because I'm speaking to the choir here, many people in the room have already seen this, read it, and have already started implementing a lot of these good practices. And the practices have evolved over time. So recent events in sepsis management really has to do with managing the host's response and implementing a bundle approach to management in care. 2002, the Surviving Sepsis campaign began. The Surviving Sepsis website was pushed out, and we started reading about the research and learning about the practices that we needed to deploy for this, for our patients that had sepsis. 2004, the Surviving Sepsis Guidelines for Management of Severe Sepsis and Septic Shock put out in the Journal of Critical Care Medicine. Some updates to that in 2006 in Chest magazine. The Marinoff Symposium, sponsored by the Global Sepsis Alliance in Garden City, New York in 2010. Another update in 2012 for the international guidelines for management of severe sepsis and septic shock by the Surviving Sepsis Campaign. And as we all know, we now have a new CMS core measure, SEP1 core measure, that defines how we need to manage this population, how we need to recognize them, and what we need to do in the early phases of care to improve these patients' outcomes. Am I talking too fast for people? Okay, all right. I wasn't born and bred in Texas, so a little further north. Now, in 2006, we actually did see a new definition for sepsis. The Society of Critical Care Medicine and the European Society of Intensive Care Medicine pulled together a task force to look at sepsis and to come up with a new definition that was published in JAMA in 2016. And the definition of sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. And again, I really need to focus on the dysregulated host response. So remember, an infection can start the inflammatory process in a human body, and a host that responds in a toxic way can move into sepsis. I really like these posters that we've got in the back. If you have some time after the program or during a break to take a look at those, it does go a little bit deeper into the specifics. So take a look at those, and they do a really good job. They're from the World Sepsis Organization website, so if you like those, you can pull them down and share the information with your own colleagues. But take a look at that, because it breaks down the definition of sepsis and what we do about it into really easy to understand language that you can easily take back to your organizations. Now, a subset of our septic population will go into septic shock. And the definition, according to this task force now, is that subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. A lot of our patients get septic and they survive. A lot of our patients will go into septic shock, and some of them may not recover from that. So again, now we're talking about end organ involvement that results in an increased risk of mortality. So our goal in general is to reduce morbidity and mortality from sepsis. And there are things that we can do that will help improve our patients' outcomes. And one of the things that we discovered, although it was no surprise, as we pulled together our representatives from the different healthcare institutions in North Texas, was that we were all trying to do the same thing. We have different ways of getting there, but we found that there were some key pieces that were consistent across the board, and that is what we were hoping to see, and a lot of those things are things that we want to share with you. And then there were some best practices that really rose to the top, rose to the surface, that we wanted to share with you to help coordinate your overall response in your system to the management of this patient population. So my background, I worked 18 years at John Peter Smith Hospital. While I was there, I was in the trauma program, and I was an injury preventionist and educator. And so I talk about the 4 E's of injury prevention, and I realized as I was putting this slide deck together that these things really can impact our approach to the management of sepsis and other healthcare conditions. So when I talk about the 4 E's, I talk about education and engineering and enforcement and economic incentives. And while I may not get very far with just educating people, we've been educating people about wearing seatbelts and not drinking and driving and no texting and no reduction of smoking habits for how many years now. And education, we know, is not going to be the fixing solution. So if we can wrap more education and enforcement and economic incentives, the more of these 4 E's we can deploy as part of a comprehensive approach to a condition, the more likely we are to make an impact on the outcomes. So in looking at education, we want to increase awareness and education of clinicians and the public. So we know that the point in time where we can do the most good and have the biggest impact on patient outcomes is before they drop their pressures, is before they look really, really ill. we can have a big outcome on them. So we have to have the public help us in recognizing when they're at risk for sepsis and come into the hospital sooner so that we can deploy these best care practices. We also want to improve our care resources so we can engineer our system so that we have those care resources readily available. We have people who can recognize when patients are meeting sepsis criteria. We coordinate our care so that we can efficiently and effectively pull all those resources together. We collaborate with each other from EMS to the emergency department, through the ICUs, and all of the other partners in care that make a difference in outcomes. And we have to share our best practices. We have to monitor compliance with these best practices and get the information out there. Part of the enforcement is this SEP1 core measure, now making this data transparent. Hopefully you've been transparent with this data in your own institutions, but now we're going to see a lot more transparency across the board for how certain organizations are doing in the management of this condition. And then also the economic incentives. There are some funding incentives to meet those criteria as outlined in the SEP1 core measure. So we do have a lot of other, so here's our awareness sepsis, World Sepsis Day, so it's in September, SEP, get it, sepsis, SEP. So think about sepsis when it's September, and World Sepsis Day is September 13th, 2016, so we just had it this past month, and hopefully you can use this day to increase the awareness of the public and also of your clinicians to the need to wrap good resources and care around these patients. And then of course CMS, other partners in care to help us improve. So the drivers of care, or drivers of change in sepsis management, I put your resource here as well, comes out of the American Heart Association, U.S. Department of Health and Human Services, and an educational task force affiliated with the American Heart Association. And this is the Severe Sepsis and Septic Shock Change Package 2016 update. Identifies these drivers of change in sepsis management. Key is reliable early detection. So universal screening, a reliable screening tool at the beginning or at the onset of care, and an infrastructure when patients screen positive on your tool, an infrastructure for rapid escalation that we've got a patient that needs this bundle of care and that rapid pulling together of the resources. And of course this bundle approach, we can have such a huge impact on our patients when we use this bundle approach. It's not going to be enough just to do one of the care items in the bundle or two. We have to take that entire bundle and we have to follow it and deploy this bundle for our patients. So there's now a 3-hour bundle for severe sepsis, a 6-hour bundle for septic shock. And again, we need to have that infrastructure for rapid intervention and response. And then there's other supportive therapies we talk about, and the compliance piece where we monitor, track, and report how well we're doing with our bundle compliance. And we know this approach works. So this is just a graph of data. At Baylor, we started our journey towards sepsis. We actually had Emmanuel Rivers out to talk to our critical care and ED physicians back in about 2003. So early on, we deployed a screening tool really early on. It's evolved over time as the care bundles have evolved as well. But this is about a 3-year period. We were measuring mortality rates using HSMR. That's a mortality ratio where we look at how many patients we expected to die based on the diagnosis and procedure coding and how many patients actually did die. The best number is 1. Well, not the best number, but 1 means, the ratio of 1 means that you had this many expected deaths and this is how many deaths you actually had. So a 1-to-1 ratio. The lower you go, that means that you had this many expected deaths and this many actual deaths. So the lower you go, the better your outcomes and the more lives you're saving. So this is how we measured mortality in the Baylor healthcare system. And as we saw an increase in door to antibiotics time, so this is about 60% when we started, IV fluid boluses, we were getting them started within 3 hours, but we weren't getting them finished within 3 hours, so we started off pretty low at about 40%. But as those numbers increased to 80 and then 90%, we saw a dramatic reduction in sepsis mortality. And when we added up the difference in the difference in expected versus actual deaths over that 3-year period, it amounted to about 500 lives. So that's 500 mothers and fathers and children and family members and friends whose lives we impacted, and we really feel like this is the reason that we do this work, is to have these great outcomes. So I wanted to tell you this really works when you wrap this bundle approach around, do early recognition, and you follow through with the best practice guidelines. You can make a difference in the lives of patients and families and in the public health of your community. So again, the approach works. I'm a big believer and a strong advocate for the best practice approach.